Hello, this is Stephen-Castro, and I'm going to do a more traditional recording, although it will still be brief, on gastroesophageal reflux disease. These are a list of your learning outcomes. They're located in Blackboard under the lesson plans. If you have trouble finding them or locating them, the link is listed in the PowerPoint, and I'm more than happy to assist you with that if you want to go over those. Moving on. So the definition of GER and GERD, they're pretty much the same thing, just one is chronic, one is acute. GER is the backward flow of stomach contents into the esophagus, whereas GERD is just a chronic state of GER, so it's been going on for years and years. It's more serious because over time, that acid being exposed to that esophagus lining, or the esophagus lining being exposed to the acid rather, can cause changes in the cells, which we'll talk about here in just a little bit. Again, you have backward flow of the gastric contents into the esophagus. Typically, that results in that manifestation we call heartburn. It's kind of a burning sensation in the back of the chest. It can be a sign of poor nutrition. It can result in malnutrition because those contents aren't being digested appropriately. Some clients actually might be asymptomatic and they really don't have any symptoms, but others can develop that inflammatory esophagitis, again, because the acid that backs up and it kind of erodes away at that lining can cause some inflammation in the area. Pathophysiology and etiology of GERD. Again, there's a pressure difference between the stomach and the esophagus. And that little sphincter kind of helps keep control of contents in the stomach from flowing backwards. Kind of think of it like a one-way valve, really. It's just located just below the diaphragm, and it kind of helps maintain that pressure difference. The problem is, and we'll get to this on the next slide, is when you have additional pressure in the stomach that causes that content to kind of back through that sphincter and go back up the esophagus. All right, so it affects roughly 15 to 20% of adults. It's pretty common in children and infants, but it does manifest a little bit differently from adults. So just kind of be aware of that. And we'll talk about both because we are teaching across the lifespan. So for lifespan considerations again, for infants, it occurs more frequently in that first year of life, but usually most infants, before they're a year old, they'll grow out of it. It's more common in premature infants. Again, that sphincter just isn't quite developed like it should be. The etiology of GER, again, it has a little relaxation of that lower esophageal sphincter, which it relaxes to let food pass through it, let that food bolus pass through and go into the stomach to go on through digestion. The sphincter can be incompetent, is what they call it, so it's just not working right, or there's an issue with it, or that there's increased pressure within the stomach, causing the contents to bust through the sphincter and get back up into the esophagus. So contributing factors that can cause this are increased gastric volume. So if you have more volume, like a large meal in your stomach, you have a higher chance of having some of those contents back up through that sphincter into the esophagus. Certain body positions, anything that might put pressure on the abdomen, especially after eating. Again, if you put pressure in the stomach area, you're going to push those contents up against that sphincter. And if you have a problem with that sphincter, it's going to push those contents through the sphincter and back up into the esophagus. And also pressure from obesity or tight clothing. Those are some definite etiologies for GERD. Other risk factors, again, include obesity, and again, just because of the pressure that's caused in the stomach area. Excessive alcohol consumption can cause that sphincter to be too relaxed. Smoking, a hiatal hernia, and that's the hernia right there at the diaphragm, and pregnancy. And pregnancy, again, is typically just because there's more pressure in the stomach because it has to make room for the fetus. And so it puts more pressure in on the stomach contents, again, which can cause those contents to back up into the esophagus. So for prevention, what we like to teach our clients is to eat more frequent and smaller meals. Smaller meals multiple times a day. Avoid those huge, large meals if all possible. We need to avoid foods that stimulate acid production. And I want you to think really hard on what kind of foods can stimulate acid production. We do talk about some here on the slides. Avoid eating close to bedtime, because at bedtime we go and lay down. And when we lay down, we're flat, and if that sphincter is incompetent, those gastric contents can flow back and forth between that sphincter and back up into the esophagus. Sometimes we can have our clients elevate the head of the bed to reduce the pressure on the lower esophageal sphincter. Frequently, I've seen that they put the head of the bed or the feet of the bed, for the head of the bed, not the feet, put the head of the bed and maybe put them under blocks or bricks. You don't actually have to elevate just the head of the bed, but even if you have it at a certain angle, it can help with aid in digesting and keeping that food going, because, gravity will be your friend. Avoid that tight-fitting clothing, anything that will increase pressure along the abdomen or along the stomach. Avoid the smoking and the alcohol, and maintain an ideal or normal body weight. You want to kind of maintain that BMI. The clinical manifestations, again, what does it feel like? Well, a lot of times they have that burning sensation, typically after eating. And sometimes it happens when they bend over or if they recline, again, because if you don't have a path of resistance, it's going to have an easier flow. There may be some painful swallowing or some regurgitation. Sometimes you get that sour taste in the back of the mouth, or atypical chest pain. There is a difference between acid reflux chest pain and cardiac chest pain, and even lung type of chest pain, like with a pneumonia or bronchitis. They all kind of manifest themselves a little bit different. This type of chest pain is more of a burning sensation that happens kind of in the center of the chest, right behind the sternum. Complications from chronic GERD can lead to esophageal strictures, and that is where, because of the constant inflammation with the esophagus because of the acid, it really disrupts the cells and the lining of the esophagus, and it causes the esophagus to get a little bit narrow, and that can happen with chronic cases again. But over time, those strictures can get a little tighter and a little tighter, and it may cause people to have difficulties swallowing foods, and they may get a food bolus stuck in their esophagus. So it can lead to esophageal strictures, Barrett esophagus is a condition where the lining of the esophagus starts to have cellular changes to precancerous or cancerous types of cells. Again, that acid is very abrasive to the esophagus. It's a little bit, the lining of the stomach is very different than the esophagus. So that acid that's in there, that hydrochloric acid, is really not meant to be in contact with the lining of the esophagus, and it can cause those cancerous changes in those cells over time. With the pediatrics, again, the effects and complications are a little bit different. Usually their complications happen, or they may have the issue when they start to swallow or cry. Excuse me. They may have a delayed esophageal clearance, or they may have a delayed gastric emptying time. So the food kind of sits in their stomachs a little bit longer. They tend to have a little bit more highly acidic gastric contents as well. Babies may be born with a hiatal hernia, and sometimes there may be some adjoining neurologic disease that causes the incompetent sphincter. Complications in pediatrics may include, again, that esophagitis, those esophageal strictures, the Barrett esophagus, and possibly anemia because of that esophageal erosion if there's any bleeding involved. Other complications may be laryngitis, and that's just kind of a sore throat, painful throat, recurrent pneumonia, if they aspirate any of those contents, and potentially asthma. Some diagnostic tests for acid reflux include a barium swallow, and they get to swallow the barium media, and that basically allows everything to kind of glow on the radiograph. An upper endoscopy, and that's basically they'll go down the esophagus with the scope so they can look at the lining of the esophagus and take a biopsy if necessary. A Bernstein test is still listed, but it's really obsolete at this point. So I'm just going to just list it there if you see it anywhere, but it is not going to be on the test, on my test whatsoever. But you may see it in your reading somewhere. There's something called a 24 ambulatory pH monitoring, and they basically kind of monitor the pH levels. They will put a little catheter to slide it down the client's nose, and it kind of goes down into the esophagus, and it kind of records the pH levels of a couple of different spots along the esophagus, just to kind of like test the liquid coming back from the stomach to see if it's really acidic or not. It typically stays in for 24 hours with the stomach. With the manometry, it's basically kind of put a tube down the esophagus, and it's going to kind of measure the different type of contractions. Remember, you kind of have those pulsations and contractions to push the food down into the stomach. And so as you swallow, it'll kind of like monitor those contractions as the bolus goes down into the stomach. Try this again. Pharmacologic therapy is a common treatment for gastric esophageal reflux disease. Excuse me. Some of the frequent medications that you may see are PPIs, omeprazole, lansoprazole, any of those prazoles. And remember, I want you guys to learn medications by class. Those are going to be your PPIs, and typically those are going to be a once-a-day dosing, and you take it first thing in the morning, about 30 minutes before meals. It helps reduce those secretions and kind of help promote healing of the esophagus. They frequently give this into the hospital just because you have decreased bowel motility and decreased motility altogether, and it helps aid in digesting and kind of reduces that acid and keeps them from having potential complications. You have your H2 receptor blockers, such as famotidine, cimetidine, and ranitidine. Famotidine right now is probably the most popular. That's the Pepcid. I'm sure you've heard of Pepcid before. Zantac is also very popular, but currently it is pulled from the shelves due to the FDA because they've had some contamination issues. I am not sure when they're going to put that back out on the shelves, but when it was out and safe, it worked really effectively. There is something called a pro-mobility agent that's called metoclopramide, or the trade name is Reglan. It helps kind of encourage digestion of those foods. It aids in digestion. So it helps kind of encourage things to move along so they're not sticking around long enough to regurgitate. You see that frequently as well. Remember, all testing for all medications will be in the generic form. So I encourage you to write all your medications in generic and to learn them by generic. And this little list that you have here on this slide should be helpful for you for the exam. For pediatric treatments, they typically just do some conservative management. Mainly, it's just kind of education for the parent, just keeping them in the proper position after eating, keep the head of the bed, or keep the infant elevated upright 30 minutes after the feedings to help aid in digestion and keep that food to go. Remember, gravity is going to be our friend. Again, smaller, more frequent feedings, not unlike the adults. Occasionally, they can give some medications such as ranitidine. Again, the Zantac is kind of like pulled from the shelf right now, but the famotidine is another viable option. That's going to be the Pepcid. They also may use the PPIs. Surgery in severe cases, there's a surgery called a Nissen fundoplication, where they kind of take the stomach and they wrap it around that area where the sphincter is to kind of tighten up that sphincter and make that sphincter kind of work a little bit more effectively. But this is in severe cases. This can happen in both infants and adults in most severe cases where they can do that Nissen fundoplication. Nutrition and lifestyle management. Again, most infants outgrow Gerd, or it's actually Gerd, not G-E-R-D. It's kind of not the disease because typically it's not quite a chronic disease for infants. But for adults, again, it's often chronic. Some dietary and lifestyle changes may help reduce symptoms if they can lose weight. Smaller meals elevate the head of the bed and kind of prevent some of those long-term effects of Gerd, including that Barrett's esophagitis, which may lead to cancer. Here is a slide that kind of talks about that surgery. I talked about that Nissen fundoplication. Say that 3 times real fast. You can see there's the esophagus, and they kind of wrap the stomach around the esophagus and around where that sphincter is to kind of aid and keep it nice and tight to allow that food to go down, but not to come back up to keep that food from being regurgitated. Focus on alleviating those symptoms. A lot of client education with Gerd and Gerd. And remember your assessment. You're going to do your abdominal assessment. It always begins with a comprehensive health history. Remember, if they complain of chest pain, you want to get additional information. Describe the pain. When does it occur? What associated symptoms do they have? Those types of things. We may need to focus on that epigastric tenderness for assessment if it's related to Gerd. Some potential components of the health history, again, for pediatrics, because remember, we have to talk to the parents, so we have to get that information from them versus the actual client. It's that recurrent or vomiting or regurgitation, but it is not projectile. They may have some weight loss or poor weight gain because they're just not getting the nutrients like they should. Infants are often irritable because they're not getting enough nutrition or not getting it fed enough. They may have some respiratory problems, cough, wheezing, because they may inhale some of that acid, and it may lead to asthma. There may be a hoarse or a sore throat because if that acid gets back up into the throat, it may cause some hoarseness or pain. It may cause bad breath in some of the older children, heartburn, chest pain. They may not want to eat because it's painful, and it may cause some abdominal pain associated with it as well. For planning, for our nursing planning, again, priorities to just relieve that discomfort associated with GERD and focus teaching on preventing the symptoms. What can we do to help prevent them? And avoid those long-term consequences of the disorder. If we can get them under control, we can avoid that long-term consequences, such as the Barrett's esophagitis. We're going to provide a lot of education to our clients to help reduce pain, make those long-term healthy lifestyle changes. Smoking cessation, maybe alcohol cessation as well, to try to prevent additional those modifiable behaviors, is what I would like to call them. The modifiable behaviors such as smoking, alcohol, and weight, their diet. Administer any medications as ordered, especially those medications, the PPIs, or the H2 blockers, H2 antagonists. Encourage the clients to use that pharmacologic therapy even after the symptoms improve. Frequently, the clients will say, hey, my symptoms are all better. I don't need this anymore. It's because you're taking the medication that your symptoms are better. So they need to continue to take that medication on a long-term basis, especially those clients with the chronic GERD. Some additional pediatric considerations include promoting safe feeding habits, smaller, more frequent feeds. Get that slow flow nibbles to give them a slower feeding time to allow them to digest the food. Thickening the feeds to keep gravity. If it's heavier, it's going to be able to kind of stay in the stomach and it's not going to regurgitate as easily. Make sure the infants stay upright at least 30 to 40 minutes after feeding. And there's older children, just like the adults, you may want to elevate the head of the bed. Prop the bed up on the head. Restrict the meals for several hours before bedtime. We don't want them to eat and go lay down flat. So to evaluate, we need to see if our interventions have worked. Hopefully they've expressed they're free from heartburn, that they're not having any pain, and that they verbalize that they're the appropriate lifestyle changes that we've taught them, and being able to demonstrate the ability to manage their symptoms appropriately. Here is a list of references for you. Again, if you have any questions for me at all, you know where I'm located, and happy studying.